So IBD and active inflammation, as with any major illness, can result in abnormalities in menstruation. It's usually a reaction to kind of the overall health of the patient, so that can be experienced in other disorders as well. In general, with normalization of the inflammation, with treatment that's appropriate for inflammatory bowel disease, the menstrual cycle should return to normal. So in general, women with IBD have basically normal fertility. There are a couple of exceptions that we do take into consideration. One is certainly the absolute normal, the absolute best chance to conceive a pregnancy is usually when the disease is under good control. So we certainly focus on making sure that the potential mother is in as good health as possible in terms of treatment of their inflammatory bowel disease. And that can also go a long way in terms of having a safe and healthy pregnancy. In addition, there are some people with inflammatory bowel disease that have to undergo surgeries in the pelvic area. That can lead to some special situations regarding fertility that will need to be discussed beforehand with both the gastroenterologist and the surgeon. So continuing medications for IBD during pregnancy is a very important topic to discuss with your gastroenterologist and obstetrician. There are some considerations to think about. One is we want to do our very best to maintain the health of the mother. That's our best chance to maintain a safe and healthy pregnancy. The second consideration is what medications you are on. There is one medication in particular called methotrexate that is used in Crohn's disease and is being tested in ulcerative colitis that is not safe to use during pregnancy. So it needs to be discontinued at least 6 months before conceiving. The other medications in general are safe during pregnancy, but there are some special considerations to discuss with your gastroenterologist during pregnancy in terms of whether certain doses should or can be held before delivery. There is thought to be some genetic component to inflammatory bowel disease, in that there is some sense that it can be hereditary, but that certainly isn't the whole story. The risk for the child when they have one parent with IBD has been estimated in studies to be anywhere from 1% to 7%. So there's a little bit of variability in what we know about that. When both parents have IBD, the risk certainly does go up to about 1 in 3. And so it's important to kind of be aware of the family history, and if there are any symptoms that are concerning for IBD, to have your child see their pediatrician for a full evaluation. So IBD can be a risk factor for osteoporosis in a couple of different ways. Crohn's disease in and of itself is an independent risk factor for osteoporosis. So in all Crohn's disease patients, we need to keep an eye on the bone density, and that's usually done by periodic testing with what we call a DEXA scan, or a bone densitometry scan. We also pay attention to appropriate calcium intake, as well as testing for and treating vitamin D deficiency. Ulcerative colitis does not carry the same independent risk. However, in both Crohn's disease and ulcerative colitis, patients can sometimes be treated with medications like corticosteroids, the most common of which is prednisone, that does decrease the bone density with chronic use. So in patients who have been exposed to steroids, that's another indication to keep a close eye on their bone density as well.